thank you for taking time out of your day to spend some time with us and talk about all things CP related. This is the first in our series, and the purpose of the Lunch and Learn is to work, engage, interact, and help to support the people in our community. And this community comprises parents as well as therapists, orthotists, doctors, and of course, other people interested in the care of those with cerebral palsy. It's an hour-long program. We're going to probably do it quarterly. And the topics are really open to whatever you would like them to be. So we would like to hear from you about things that you're interested in. Today, you're going to hear from myself, Lisa Yoon, as well as Nikki Bainton, our nurse practitioner. I want to just talk a little bit about the Weinberg Family CP Center. I think most of you are familiar with it to some degree. We are actively engaged in patient care, research, and education. The patient care involves everything from the identification of cerebral palsy in the neonatal intensive care unit to the treatment of adults, and of course, in between. So we provide clinical care as well as care coordination. Jennifer Pimentel is our care coordinator, and she is outstanding at helping families and individuals navigate both the healthcare system as well as solve whatever social issues that may come their way. We have an outstanding mental health program. And we have social workers, psychotherapy, and psychiatry services as part of it. We have a very robust basic science as well as clinical science research platform. Jason Carmel, who is the director of the CP Center, is a world-class researcher in cerebral palsy and spinal cord injury, and he heads up the Movement Recovery Lab, is an integral member of the CP Research Network, as well as the genetics project here at Columbia. And then lastly, we have what we're doing today, education. We have an annual Lindenauer lecture series. We have this Lunch and Learn. There are community webinars throughout the year. And then we have a repository of information on the website. So there's all aspects of CP issues are really managed very nicely by the Weinberg CP Center. We are a lifespan center. We take care, I mentioned, children through adulthood, infants through adulthood, and we also are multidisciplinary. So we, of course, myself, I'm an orthopedic surgeon, and we have a number of orthopedists, both pediatric orthopedists as well as adult orthopedists, to provide clinical orthopedic care. We work very closely with our neurologists and physiatrists. I mentioned that we have our mental health program, both psychiatry as well as licensed clinical social worker. And then, of course, we have care coordination and orthotics. This is just a picture of some of the people on our team. You can see who the orthopedic surgeons are. Dr. Carmel, Lynn Cadis, and Jennifer Bain are our neurologists. Dr. Azizi and Elizabeth Bates provide our physiatry services, and Lisa Yoon is our physical therapist based within the CP Center. Our mental health services are provided terrifically by Jessica Dodge from psychiatry and Manelli Vasquez, who is our licensed clinical social worker. And then administratively and from a care coordination perspective, we have Jennifer Pimentel, Belkis Tavares, and Emily and Jacqueline Chen, who round out the team and really provide the bedrock of our program. We also have a primary care team. These are primary care doctors who have an interest in as well as an expertise in taking care of people with childhood onset disabilities. And they are actively engaged with us in the Weinberg Family CP Center. And we work with them and meet with them twice a month during our multidisciplinary clinic. You can get more information about who these people are and how to make appointments with them through either Belkis or Jennifer Pimentel. So today's speakers, we have Lisa Yoon, who is a doctor of physical therapy. She's got over 25 years of experience treating infants and children with childhood onset disabilities. She's done school-based therapy as well as private home-based therapy, and has now joined us at Columbia and at the Weinberg Family Center, and not only has a terrific experience and interest in treating children with CP, but also educating other therapists. And I think you're going to get a lot out of her talk today. Myself, I'm the clinical director of the Weinberg Family CP Center, and I've been actively engaged in the treatment of people with CP for the last 25 years of my career. And I'm really very happy to be getting this thing started so that we can engage more with all of you. And then lastly, integral to the clinical care aspect of what the Weinberg Family CP Center does is Nikki Bainton. Nikki has been with us for 15 years at Children's Hospital of New York and with the Weinberg Center since its inception. And I would argue knows more about our patients than anybody else on our team, but more importantly, really provides outstanding care to everybody. So with that, I am going to give this off now to Lisa Yoon for her first talk. The format's going to be Lisa will give a talk. We'll have some time for questions. Then I'm going to give my talk on hip surveillance, and then we'll have more time at the end for questions. You'll see you can enter your questions through the chat. And I look forward to hearing all of your thoughts. Lisa, please begin. I'll stop sharing my slides.
That would be great. Okay. Okay, is everybody able to see the screen well? Okay. Welcome, everybody. Thanks for joining us. I am really honored to be here and invited to speak on behalf of the Weinberg Family CP Center. Before we start, I wanted to do a little poll to get a sense of kind of who you are and what settings you work in. So I don't see the poll function. Let's see. Okay, here we go. And so if you could go ahead and answer the poll questions, that would give us some information about who you are and perhaps what you're most interested in. And then hopefully I'm going to share this result so that we all know who everyone is and perhaps can cater the talk a little bit more to the population that's represented. Okay, I see the poll is working, so that's really great to see. I'm going to give people just a few more seconds to respond. Hopefully you found that poll button where you can respond to the question, and I see less response. So I'm going to end the poll and kind of share the results. And so it looks like about 59% of you are physical therapists. There's a smaller percentage of occupational therapists. There's some educators. 14% are caregivers, 3% orthopedic specialists, neurologists, physical medicine physicians, and then others. And in terms of settings, we see that it's a fairly equal distribution, which is really nice. We'll get a perspective from the hospital-based therapists and people that represent the hospital setting, those from the outpatient clinic, a school, and then home. So thank you so much for sharing your information. And I'd love to get started. So the agenda today is, of course, to talk about CP and what that means in terms of lifespan care, the role of the multidisciplinary team that includes a patient, parent, and caregiver, the medical and rehab professionals. And I'm sorry, I should have also written educational professionals. We certainly view education as a big role. Talk a little bit about clinical decision-making, pre-surgical considerations, and really priming the post-surgical journey. General timelines and rehab guidelines for orthopedic surgical procedures, and then finish off with a little bit of Q&A, and then I'll hand the mic over to Dr. Hyman to finish the hip surveillance piece. So in terms of background, this is the definition of cerebral palsy. I think everyone on this call probably is very familiar with this. It's a group of permanent disorders of the development of movement and posture, causing activity limitations attributed to the non-progressive disturbances that occurred in the developing fetal or infant brain. And so I underline non-progressive because sometimes that gets us into a little bit of trouble and can be misinterpreted as being something related to function. When they're speaking of non-progressive, they're really referring to the brain injury. But of course, many of us who work with people with CP know that there are many secondary effects that do impact somebody's function over time. And so this talk is about surgical interventions, and we know that effective lifespan care requires both anticipating, monitoring, and managing those secondary complications. And that includes surveillance, which Dr. Hyman will talk a little bit more about, that may lead to consultation with various professionals. We're going to briefly mention the non-surgical interventions, but mostly today we'll be talking about surgical interventions. And then, of course, we can't forget the things that are mainstays in care of people with CP, which are the therapies, the assistive technologies, and the supports. So what is the role of the patient or parent, rehab, educational, and medical teams? Well, it is our duty kind of to work on surveillance. And what is surveillance? It's really that careful monitoring, observation of something very specific. And so we're looking at things like changes in endurance and or function, differences in a person's alignment, their pain experience, their weight-bearing tolerance, or their bracing needs. And so these can signal changes that would initiate that consultation that I spoke about earlier. We're also going to do a lot of baseline assessments. So just getting a sense of what the person can do in terms of their musculoskeletal system, their neuromuscular system, and of course, function. In terms of the types of conservative interventions, again, these are things that are mainstays of care for people with CP. And although we're talking about surgical interventions, these are concurrent with surgical interventions. And those are bracing, assistive technology that includes things like seating and mobility, gait trainers, sanders, and assisted devices, as well as pharmacological interventions, baclofen, Botox, phenol, and the like, as well as therapy. And of course, that includes all types of therapy, not only PT and OT. So in terms of clinical decision-making, we know there's a spectrum of choices. And so this figure to the right here kind of describes some of the choices. If we're looking at the arrow from inferior or bottom to top, we can see the ones on the bottom are more focal in nature. The ones at the top are more global. The ones to the left are reversible, and the ones to the right are irreversible. And so when we're thinking about that, we're considering some very important factors. Those are age, growth, the goals of the intervention, and the resources and supports that the person may have. We also have to consider things like feasibility of the particular intervention, the timing of the intervention, and the commitment to rehab. This is not a small thing that we're asking of the family nor the team and the supports. And so today we're going to talk mostly about surgical interventions. If we classify surgical interventions broadly, we can see that they fall into one of several different buckets. One is soft tissue releases, another is tendon transfers, a third is osteotomy, and then what's called single event multi-level surgery, or SEMLS for short. And so we'll talk a little bit about each type and hopefully go through some rehab guidelines and timelines for healing. Important to any discussion about surgical interventions are those pre-surgical approaches to rehab. So pre-surgical being those things are really important for priming the post-surgical course. This, of course, starts with a consultation and examination by perhaps an orthopedic team, since we're talking about orthopedic surgery. We're going to discuss at that meeting surgical intervention and kind of determine the goals for this procedures and the expectation. This cannot be highlighted more as one of the most important parts of this initial process is to make sure everybody is on the same page with regard to what is going to happen and what the goals are and expectations for success, a successful intervention. Timeline for rehab is very important, as well as home and school considerations. So we know kids go to school for a large chunk of their day. And of course, the home environment is expected to be affected as well. So thinking about those environmental and care needs post-surgery, whether that be equipment or personnel related. We're also going to have a discussion with the person that is undergoing this intervention, as well as the homes and school teams to coordinate this particular intervention. And as I'm going to do a shameless plug for therapy, I think therapy is an incredibly important piece of this pre-surgical approach. And many, once they hear that the child is going for surgery, decide that, oh, that means that therapy, we can kind of stop therapy, or we can kind of slow down because surgery is going to fix everything. And that really couldn't be further from the truth. There's much information about therapy, pre-surgical interventions being very important to post-surgical success. So I liken kids who go in weak are not only going to come out weak, but they're going to come out weaker. And so really important as a therapy team, if you know that your child is going to have a surgical procedure, to ramp up therapy in terms of strengthening work on power and function. So as I mentioned in the last slide, I think really having a great planning meeting to discuss the ins and outs is really important. One of those things that is really crucial is determining the goals of the intervention and why this particular intervention is important at this particular time. And so I put this ICF framework, which many of my students at the program know very, very well. Hopefully many of you who are health professionals know this. I put this particular diagram up because it not only targets the things that we know as a part of the ICF framework, but it lists it more in a parent and a child-friendly way. So when you look at this diagram, this gives you a roadmap into determining why are we doing this particular procedure? What is the expected outcomes? And we start on the far right where it says participation. What is that child's role in life and what are we trying to get back to or to improve? The next is activity. What are the things that the child cannot do, or maybe the parent has difficulty assisting the child to be able to do, that is limiting their participation? And of course, where we also come in is at the body structure and function level. What are those specific things that perhaps surgery can address, meaning flexibility, range of motion, things like that, that will enable a child to be able to do all the things that they want and assume their life role. At the bottom, we're considering those personal factors, those things that really make an individual and affect their rehab course. So what do they bring to it? What is their disposition? What is their tolerance? What is their understanding? And how likely will this intervention be successful from a rehab standpoint? We're also looking at the environmental factors, those things that really set the child up for success and the family up for success in all different environments. These are things that will help support the rehab journey. The other pieces I'm going to put in red, and those are the things that families and children talk to us about. And that is, how can I get back to playing with my friends and being with my friends, which is the same as participation for them, as well as functioning. How can I do the things that I want to do that will enable me to play with my friends or return to the things that I love? I may need help with fitness and achieving those goals through surgical intervention, improving range of motion that will enable me to get to where I need to be. And of course, don't forget the fun and my family that are critical for success as well as the future. So what my future entails, both in the short term and in the long term. So I find this ICF framework really, really helpful, not only as a health professional, but describing it and coming to some consensus with the family. Post-surgically, in terms of rehab, we know that early mobilization is very, very important to post-surgical success. And what that means is that there is a gradual increase in activity beginning immediately post-operatively. Now, early mobilization does not mean getting them up and doing the exact same things that they were able to do immediately, but really accelerating that time frame to get them back to what they know and love. This includes early return to school and therapies, depending on the 3 Ps, which are the patient, how they presented pre-surgically, the type of procedure that they underwent, and of course, the protocol as determined by the surgical team. Also important is timely scheduling and attendance for post-operative appointments with the surgical team. This is where you're going to have a discussion about what can be done in terms of rehab activities and maybe precautions that you should adhere to. And also this, I should underscore, regular communication and exchange of information from all team members. And this may be done through the parent. It can be obviously done directly with the person, but regular communication, both to and from home and school teams, to and from the parent, and the medical, surgical, and additional rehab teams are really crucial for success. And so now what I'm going to do is talk a little bit about general timeline and rehab guidelines for a particular procedure, which is very common. It's called a soft tissue release. I'm sure many of you have had patients undergo this procedure, and I list it first because it's the least complicated of all of the 3 that I'm planning on discussing today. And so starts with post-op. Obviously, pain management is super important, passive range of motion, bed mobility, positioning, transfer training, and sitting tolerance are early goals immediately post-operatively. And then when we look at weeks 1 through 3, we're talking about positioning. Again, it could be progressive, so no longer maybe in bed, but at a chair and doing more functional things. Active assistive range of motion leading to active range of motion, meaning that the child is actually moving their joint through their available range. And then, of course, progressing to some gentle stretching and muscle activation. So as you know, whenever you undergo a surgical procedure, muscles kind of need time to figure its function again. And this happens not only just in people with CP, but for anybody who undergoes any type of surgical procedure. So establishing that connection and that muscle activation pattern is really important. And then, of course, progressing from sitting tolerance really to sitting and standing balance. Somewhere between the 3rd and 4th week, probably the surgical team will want to schedule an office visit to really look at how tissue healing is occurring, if there's any complications and things like that. And then a discussion is had about return to school and therapies, reassess any restrictions and or modifications to weight bearing or activity, and obtaining that letter kind of to get back to school and to therapies. Somewhere around week 4, and again, this is a flexible timeline, so your particular case may be accelerated. It may occur a little bit later, depending on what happened in the operating room. At week 4, you're really returning to school therapies. Hopefully by that time, everything has healed well enough for the child to be able to go back to school. There's going to be a progressive increase in their sitting and standing. Obviously, before they go back to school, we want to make sure that they're well set up in terms of the environment and are able to tolerate all these different position changes during the day. And then stretching, active range of motion, and balance, whether that be sitting or standing balance, are initiated. At weeks 6 through 8, we're going through more progressive resistive exercises and activities. And at the very end, we'll talk through kind of the guidelines in terms of how you might progress exercise depending on a child's tolerance and, of course, the kind of procedure that they received. And hopefully by this time, it's full activity as tolerated for the particular child. So this is a general timeline and rehab for those who have undergone some sort of pelvic or femoral osteotomy. This is a bony procedure, so a little bit more complicated in its timeline. Inpatient is really it's very similar in terms of pain management, and I underscore pain management because that really can affect a child's tolerance and ability to participate. So having a discussion about pain management is crucial. Your child will probably use some kind of positioning pillow for the first several weeks. You're still going to work on bed mobility and transfer training. This is really important for both the caregiver and the child. And of course, if you can initiate this before the surgery in terms of simulation, I think that would also make post-surgical transfer training and bed mobility much easier to understand. You're doing range of motion and, of course, upper extremity strengthening, knowing that perhaps weight bearing will occur a lot through the arms and through different body parts that may not have had to assume so much weight. So strengthening of those extremities are really important. At week 1 through 6, you're having a variety of different restrictions and check-ins. So you're going to have a first post-op visit at day 10 to really assess incision healing, maybe remove bandages. You're still going to use the pillow probably for several weeks afterwards, depending on the surgical team's decision. You're going to initiate gentle passive range of motion. Again, understanding that there will be restrictions to particular motions, and then a period of non-weight bearing because this is a bony procedure. Sometime after that, you will have an office visit where there will be a pelvic x-ray and a physical exam to assess healing. You're going to review again the range of motion restrictions, weight bearing and activity restrictions and things like that, and perhaps progress to a more partial weight bearing status. And then week 6 and onward, you're going to work on progressive sitting tolerance, again, depending on what procedure you had, and sitting balance. So it could be in a fully upright position with feet on the ground, depending on what is tolerated and what has been cleared by the surgical team, as well as some participation in transfers and assisted standing and standing programs. Another office visit will likely be scheduled sometime at the 3-month period, again, to look at healing to determine what the weight-bearing status restrictions might be. You're returning to school, hopefully, because some of the casts and restrictions have been lifted, and the child's able to tolerate a full day of sitting activities or have a chair that can be reclined. They are also participating more in transfers and also in a progressive standing program. This last one is a general timeline. This one is a little bit more extensive because it's what's called a single event, multi-level surgery, SEMLS for short. Again, it's one of those procedures that describes surgical intervention at 2 or more levels with one operating journey and rehab, hopefully. And so if things can be done simultaneously, sometimes that is opted for. Again, because this is a more complicated procedure, you will notice that the timeline is a little bit more extensive. But again, because the child is undergoing one anesthetic event, one operative day, and also journey, sometimes this is the best way to address some of the goals. So post-op, again, looks very, very similar. A little bit more extensive. There may be more weight-bearing restrictions and activities per the surgeon, again, depending on how many levels were involved, what extremities were operated on, if it was bilateral, unilateral. Weeks 1 through 4, again, you're looking at wound checks and making sure that tissue healing is underway. You're looking at an intensive rehab process that includes things like active range of motion, active assistive range of motion that progresses to active range of motion, and of course, progression of sitting and standing tolerance per the surgeon. At this time, you're going to have an office visit whereby the cast, again, is going to be reassessed. It may be cut down depending on what procedure you have and depending on the 3 Ps, how the patient presented pre-surgically, what the procedure was, and the protocol, and have another X-ray performed. At weeks 6 through 12, we're discussing, this is not always set in stone, but when can a return to school happen, dependent on how the child is tolerating sitting, being able to sit in a chair for a prolonged period of time, or if the chair can accommodate different positions. You may be further removing a different piece of the cast, and then perhaps having a walking cast as well. At week 12, which is somewhere around the 3-month period, you may have another office visit. And there you really discuss kind of the needs in terms of bracing that may be different from pre-surgical needs, assistive technology, medical equipment, things like that. And then you're also, based on the X-ray and how tissue is healing, initiate a progressive strength and function program. Because this is a very extensive procedure, again, this has many more check-ins, but we anticipate that somewhere around the 6-month mark, that pain would be a little bit less prominent and that you can really ramp up the progressive strength and function training at this period. You will also have another office visit to remove any remaining casts and review precautions and weight-bearing restrictions based on tissue healing. This is week 36, and so sometimes this is a scheduled visit, sometimes it's an optional visit, depending on what has happened at the 6-month visit, and continue on with progressive strength and function training. And then really looking at monitoring how kids are doing 1 year post-surgical intervention. And at this point, really, you're returning to many of the things that the child was able to do and maybe beyond at this point. But the literature says that really there is continued improvement up to 2 years post-operatively. So in terms of this post-operative expectation, we know that pediatric clients undergoing SEMO, what we can expect is perhaps improved gait patterns, but that other changes in gross motor function, quality of life, and participation is mixed and obviously is dependent on who the child is, what procedure they underwent. What factors predict improved outcomes? We know that kids that have higher GMFM scores, that's a gross motor function measure score, pre-surgically tend to do better post-surgically. We also know that therapy dose post-surgically, as well as surgical burden or how many levels and complications were encountered during surgery, as well as their pre and post-operative functional levels, really predicts kind of how well they might do post-surgically. In terms of rehab, there are some general guidance, I think, that is worth mentioning for all types of procedures, and that really is to communicate with the medical team as well as the parent caregiver about pain management, meaning dosing, timing of day of therapies, and dosing of that pain management schedule so that they can maximize participation in therapy, as well as understanding the precautions and contraindications to rehab. We want to know especially what the weight-bearing precautions are. And so you'll notice that for the more simple or less complicated procedures, that weight-bearing could be weight-bearing as tolerated, Whereas for those that are a little bit more complicating, it can start with a non-weight bearing situation. So again, really important to understand what the restrictions are and how you can best help the child move forward. In terms of activity, we're starting off with positioning, of course, making sure that the joints are able to move through their full range of motion, both passively, then active assistively, and then actively. We're also going to ask the child to activate their muscle in an isometric fashion first. Once that is established, of course, going through concentric and eccentric training. We're going to target that agonist muscle, or that muscle that is primarily responsible for movement. And then again, train the antagonist, or the muscle that is opposing that particular muscle, as well as supportive muscles. So depending on what procedure your child underwent, you're going to perhaps use your supportive muscles first, strengthening those, but then following up with the agonist and antagonist muscles. We also know gravity eliminated positions can be used to facilitate movement and less stress on joints or muscles that may not be ready. So using those gravity eliminated positions, moving to anti-gravity, and then using a variety of developmental positions that are both weight-bearing positions that can be progressed through. Post-surgically, we're going to progress the child again as indicated and as tolerated. So from top to bottom, things that you might encounter initially, and then progressing all the way to function. So pain management, positioning, bed mobility and transfers, then progressing to sitting and standing or standing tolerance, both in time and also postural requirements. Targeting sitting and standing balance. So being able to assume a steady state or static position, and then moving on to reaching activities where the child is moving parts of their body out of their immediate base of support, and then following those up with perhaps reactive balance, or the ability to counteract unexpected perturbance. We're also going to look at range of motion for functional tasks. This is obviously very important: dressing, eating, toileting, and bathing. Working on a stretching routine for the muscles that were the targets of the surgery, and of course the muscles surrounding the area, as well as strengthening. Then power training. We also know that in kids with CP, that it's not just strength that is missing, but the strength coupled with velocity or power training, that's really important to work on. And then finally, but not last, getting kids back to recreation, or the things that they used to enjoy pre-surgically. So in summary, multidisciplinary care provided by the medical and community professionals is vital to provide individualized and timely interventions to people with CP at a variety of time points in their life. Optimal post-surgical outcomes start with effective communication between parents and professionals that includes pre-surgical consultation and planning. And physical therapists across all settings play really a vital role in monitoring, counseling, and educating, as well as supporting pediatric clients and their families to optimize lifespan care of individuals with CP. So here's some information I believe that will also be included in the next set of slides. But as Dr. Hyman noted, we have lots of people that support the CP Center and are our patients' first connections to the center. Here are my references, and thank you for listening. I'd love to now hand off the discussion back to Dr. Hyman.
Lisa, thanks. That was a terrific talk, a great thorough review of rehabilitation issues regarding post-surgical care. We have time for just one question. There's a question in the chat that goes as follows. Regarding pre-surgical therapy or prehab, does this differ from the regular goals of therapy? And are there specific kinds of exercises or programs that you recommend?
So, Dr. Hyman, you probably could speak some to this as well, but in terms of pre-surgical rehab, I think some of the restrictions to activities or things that you may not have been targeting specifically as a part of a goal can be restructured. So prehab to me really focuses on strength and power. So again, we know that kids with CP have lots of weakness that underlie all the spasticity and tone, and that part of prehab is really making sure that kids maximize their strength and power to be able to come out of surgery a little bit with a stronger base than would have been gone into if they had not done any prehab. So I do see that as being slightly different, whereas regular therapy might just be focused on the goals that were established. This could have a different focus, specifically for strengthening and power.
Yeah, I agree. The better, stronger you are going into your surgery, the better you will be coming out of it, without question. And that's something that we pay a great deal of attention to in typically developed kids. Kids that are going in, they tear their ACL, and we're going to repair that. We'll do prehab before that to get them up to their fighting strength as best we can. We seem to neglect that a little bit, I think, with some of the CP kids, and that's more on us, the surgeon, for not referring them in specifically for that. Just quickly, what about types of therapy, NDT or BOBATH, intensive suit therapy? Do you think any of these make a significant difference?
So I think that's a really hot topic and probably could take up
You know
many
what,
minutes.
Lisa, you're absolutely right. Let's
Yeah.
leave that be for now. That
Okay.
is a good topic for another date.
Great. Thank you.
All right, thank you very much. So I'm going to now talk about hip surveillance in children with cerebral palsy and the teamwork needed between the therapist and surgeon. And when this teamwork goes well, we are the A team. And for those of you old enough, that is a picture of the cast of the A team. These are my disclosures, nothing relative. Natural history of CP is one of displacement. That is, over time, the hips tend to come out of place. About a third of all kids with cerebral palsy will progress to some element of hip displacement. And we know that this increases with the severity of their involvement with cerebral palsy. As I mentioned, the natural history of spastic hip disease is one of major muscle imbalance progressing to hip displacement. Well, why are we concerned about hips and CP? Mainly because of pain and difficulty with mobility and seating and care. When the hips come out, they don't work as well. They also don't last. They wear out more quickly, become stiffer, more painful, and seating and mobility become difficult, as does general care, bathing, changing, and dressing. If there's a delay in the detection, this can actually diminish or restrict our treatment options and can result in bigger surgeries being performed. So we want to try and get to these earlier. And there is very good evidence that early detection can prevent dislocation as well as permanent deformity of the hip joint and ultimate pain. Just very quickly, a little review. The hip is a ball and socket joint. The ball is the femoral head. The socket is the acetabulum. And when these are in proper relationship, the two move together properly, and the femoral head remains round, and the acetabulum similarly remains round, much like ice cream in an ice cream scoop. The natural history of CP is interesting. Despite having hips that might not look very good when they're older, hips at birth are all normal. Children with CP are born with hips that are reduced, located. This is in distinction to children with hip dysplasia, where they might be born with a dislocated hips. Kids with CP are born with normal hips. By about age 1 or 2, spasticity becomes apparent in these children, and the muscles become a little bit shorter in the setting of bone growth. This causes abnormal forces on the hip joint, which can result in subluxation or dislocation of the hip. In order for the hip to develop normally, you have to have normal bone growth, normal muscle development, and these two have to be balanced to keep the femoral head in place. With the spastic, when the muscles become spastic, they tend to push and pull the femoral head out of the acetabulum. Specifically, the iliopsoas muscle, which flexes the thigh, can force the femoral head out the back, and the adductors, which bring the hip to the midline and even sometimes across the midline, will force the femoral head up and also out the back. This results in posterior superior subluxation and dislocation of the hip joint. Just a quick reminder of the difference between subluxation and dislocation. The top X-ray shows subluxation, which is a partial, if you will, dislocation or migration of the femoral head out of the hip joint. And this is measured as a percentage. It's called the migration percentage. A dislocation is when the femoral head is completely out of the joint. There are risk factors that are well known for hip displacement or dislocation, and the most significant one is the Gross Motor Functional Classification System, or GMFCS. I think most of you are familiar with this now, but quickly, level 1 kids with level 1 GMFCS are really very high functioning. They're able to run and jump, participate in all activities, often without any devices. Level 2 kids might need a little bit more help. They may use an AFO, but still are participating at a reasonably high level. Level 3 kids need more help. They are often walking with crutches, sometimes a walker for longer distances. They're using a wheelchair, and the level 4 kids can maybe in therapy use a gait trainer or a walker, but for the most part are dependent upon a wheelchair for mobility. And level 5 kids are fully dependent on wheelchairs for mobility as well as for most of their care. What we found is that GMFCS very clearly predicts the likelihood of dislocation. The kids with level 1, 2, and 3 CP really tend to have hips that stay in place. It's the 4s and 5s that we are talking about. Up to 75 to 80% of children with GMFCS level 4 and 5 involvement can be expected to have hip issues. The hips dislocate gradually. This occurs at glacial speed. This is not a traumatic event. It takes years really for it to occur, but not a lot of years. It can occur in just a few years, as you see in this example. This is a child who at 11 months of age had essentially a normal X-ray, and by 4 years of age had a dislocated hip. Once it begins to subluxate, it really rarely will get better without some form of treatment. So it's really important to identify these kids early and get to them before dislocation occurs. The process of identifying and monitoring these early indicators is really important to prevent the dislocation. And the things to look at are age. We talked about GMFCS levels, as well as the migration percentage, in which case you need to really get an X-ray and measure the progression of the hip slowly moving out of place. The role of hip surveillance, or the goal, is to maintain a flexible, well-located, and painless hip with good symmetrical range of motion. So early identification is critical, and it's quite clear that when these kids are identified early, there is a significant reduction in the need for surgery on dislocated hips. And there was a great study done, came out in 2014 out of Sweden and Norway, where they compared kids from Sweden, where there's a very robust surveillance program, with children in Norway where they do now, but at that time did not have a formal surveillance program. And the rate of dislocation was dramatically different. 0.7% in the Swedish cohort versus 15% in the Norwegian cohort. So hip surveillance has been demonstrated to be very effective at identifying kids with hips at risk, treating them, and preventing hip dislocations. The hallmark of hip surveillance is the physical exam. And it is really, it's done primarily by physical therapists. In countries, we don't have a national hip surveillance program in the United States, but in countries that do, the therapists are at the forefront because they're, of course, seeing the kids on a much more frequent basis, and they're generally much more attuned to subtle changes in physical exam. So they are aware of the level of spasticity, or the Ashworth score of the child. They are familiar with any changes in pain, any changes with sitting, standing, or walking tolerances, and of course, they're measuring passive and dynamic range of motion at the hips. If there is a concern, then we will get an X-ray looking at migration percentage. And here you see on the right is a cartoon of migration percentage, and on the left side is an X-ray of a hip that's about 50% subluxated. So what are the surveillance recommendations? Well, they vary by GMFCS level. For level 1, 2, and 3 kids, essentially these kids need to be examined every few years by the orthopedic surgeon, and an X-ray typically at about 2 or 3 years of age is sufficient. Most of these kids don't develop any hip issues. So if you get a good X-ray at 2, 3 years of age, that's pretty much all they need from a radiographic perspective, but they do need to be constantly monitored by the therapist and then referred on to the orthopedist if there are further concerns. For the GMFCS level 4 and 5 kids, they really need annual X-rays, generally between the ages of 2 and 10. And then, of course, more frequently if there are changes in physical exam noted by the therapist. I mentioned, when do you survey more frequently? Well, if there are changes in range of motion, changes in tone, any alteration to seating or gait. Typically it's seating. These kids, as I mentioned, generally are not ambulatory. If there's a change in their scoliosis or pelvic obliquity, if there's a new leg length discrepancy that's noted, if the parents are noticing a difficulty in maintaining hygiene, abducting the legs, spreading the legs apart for bathing, changing, and dressing. And then if there's a change in pain, if there's a new onset of pain or pain seems to be worsening, these are all reasons for evaluation by an orthopedic surgeon, and also likely a checkup with an X-ray. So what can the non-orthopedic providers to do? As I've just mentioned, you really be aware. First, it's important thing. The most important thing is awareness. Know that who the kids are that are more likely to develop hip displacement, and those are the more involved non-ambulatory children, GMFCS level 4 and 5 kids. Begin surveillance. You don't need to have a national program. A national program would be ideal, but it's not necessary. You can do this on your own. So pay attention to the factors that we've just discussed, and don't be shy about reaching out to the orthopedist, suggesting that an earlier evaluation might be warranted. Pay attention to the child's pain or discomfort. And of course, listen to the parents. The orthopedist might see the child once or twice a year. The therapist may see them once or twice a week, but of course the parents are with them daily and are often quite attuned to changes. So in conclusion, surveillance and monitoring of these high-risk patients is critical, and it is also evidence-based. It is clear that watching them and then acting early on is better than ignoring it and waiting for the hip to be dislocated. Early treatment is necessary and can prevent the need for salvage operations. And of course, the goal is to prevent the pain and increase mobility and improvement in overall quality of life for our patients. So I'm going to stop there. Again, this is a picture of our team. I want to thank the participants for being with us this afternoon. And this is information for how to reach us at the center, the locations where we're seeing patients in New York, New Jersey, Westchester. And I'm going to, let's see, I'm going to go, we have a couple of questions. Okay, so there's one, let's see, one question is, can you explain why the 6-monthly hip surveillance would end after 7 years of age? Yeah, that's a great question. One of the reasons is because of growth. Most of the growth occurs before 7 or 8 years of age. And there is good evidence to support the fact that if hips are reduced at 7, they will most typically stay reduced at 7. I say most typically, not always. So we'd still have to remain vigilant, but we don't generally have to X-ray after 7 or 8 years of age. There's a great question here. Can you share your thoughts on prioritizing surgical intervention on spine prior to hips? So we've been talking about hip surveillance, but there's a whole nother issue of spine surveillance that is just beginning to gain some traction. One of the big quandaries that those of us who take care of kids with CP have is when you have a child with bad scoliosis and a dislocated hip, which one do you manage first? And there is no good answer. There are good reasons to do both, to do one versus the other. But what we have found now that we are more proactive, we typically can address the hip and get it reduced before there's a need to intervene on the spine. Typically, the spine becomes a problem at an older age, 8, 9, 10, 11. A goal is to get the hips reduced and maintain the reduction before that happens. So I'm hoping that in the future, this question won't be an issue any longer. Let's see.